Hey, thanks, Doc, for everything you're doing. It's very exciting, some out-of-the-box thinking, and one thing just about the screening study, first of all, I guess to be able to do that study, you need to do some of the precursor things showing that MGUS, if we treat it earlier or if we know how to identify those patients, we could start curing myeloma to justify that type of screening study. Is that what you were saying?
Correct, yes. So before we start the screening study, you're right. We need to show if we treat early, it will make a big difference. Can you indeed cure some patients in the smoldering conditions? Can you identify which patients will actually progress or not, so that you're not just screening a lot of patients and scaring a lot of patients without having the next step already. So you're right. We're not saying we will start it today, but it's all the steps we're thinking about for the next 5 years, 10 years. What are the steps we need to do to make this a preventable disease?
Okay, great. And is this where this blood cancer prevention of progression clinic, is this where this comes in? Could you talk a little bit about your clinic and what's the focus of your clinic and how people could get involved in this clinical study?
Absolutely. So the Prevention of Progression Clinic started with the whole initiative of us saying we would love to see patients with MGUS, with smoldering disease, with asymptomatic disease. If you want to come to Dana-Farber, part of it is just a small one-page consent form that patients sign, and whenever they're getting any blood sample, routine blood sample, or a bone marrow biopsy for any clinical study, we will ask them to participate in this so that we can understand what are the changes that happen in their bone marrow or in their blood that predict progression. Because right now what we're using to say MGUS will progress to myeloma, we're using just very clinical tumor burden markers that really do not predict for us well what will happen to a patient. So the first step is understanding genomics and understanding the tumor cells and the microenvironment, what happens and why would someone progress while others does not. And hopefully with that, I can take a blood sample from a patient and I tell him, based on your profile, you will have a chance of progression of 2 years, 5 years, 1 year, 10 years, or you will never progress. But doing good molecular markers and not just tumor burden markers. So that's the first step. The second step that we said we will do with this trial or clinic is we don't want patients to only come to Dana-Farber because that limits everyone from being part of it. So we will be launching soon a crowd trial where we actually put it online to anyone who wants to participate, first in the U.S. and then hopefully we will go outside the U.S., where anyone who has the diagnosis of MGUS or smoldering disease, go ahead and sign on this online site. We will then get all the information, the clinical information from your doctor and be able to get it all into one big database that people can access. And then we will ask for a blood or a bone marrow sample if you have it, and we will start doing profiling for patients and hopefully in the future even give them back their information. So a lot of people are doing that now for like sites like 23andMe or Foundation Medicine, where they're actually giving you the profile of mutations you have, and you can be part of that whole initiative. We're hoping to do that also for patients, where we can actually profile their information and detect mutations and give back the patient's information to them and to their doctors and say, we don't know yet if a P53 mutation will be bad or good, or a KRAS mutation will be bad or good, but as we get more and more people, as we get large data sets and information, we will be able to predict more accurately someone will be able to progress and someone will not progress. Once we have that information and we have treatment options for patients, then we can go back and do screening studies in the future to say, I will be able to screen that much of the population and be able to detect MGUS and follow them and potentially cure them.
Oh, that sounds exciting. Now, that crowd study, when that opens, how can we as patient advocates promote that? And would it be like an online portal that people can register for free? Would it be something that your local oncologist would have to put you into, or are the logistics not worked out yet?
No, absolutely. So we think that patients are their best advocates for themselves. So we will be posting it online. It's free. Anyone can access it. All they have to do is read the consent form, say yes, they agree, put some basic information so that we're capable of contacting them back, and also giving us the approval to call their doctors and get the clinical information of their M spikes, their protein, when were they diagnosed, and all of that. And then we will ask for a blood sample or a bone marrow sample if they already had one or they will be planning to have one in the future. So that will be the steps that we will have on this, and we're hoping to launch it very soon. And I'll send everyone the information. And the more you tell people, the better we will be, more successful, of course.
And these are for people diagnosed with MGUS and smoldering myeloma. Is this the group of people that you're looking at?
Correct. Yes. So for anyone who does not have symptoms yet, this will be designed for that.
Oh, wow, that sounds great. Now, the other thing I'm hearing, there's all this talk now about smoldering myeloma and treating early, and possibly once you identify which group is more likely to progress and possibly maybe having a cure because of that. What information or what would you tell someone who came to your clinic who was newly diagnosed with MGUS or smoldering myeloma? What should they be doing? I mean, especially a lot of people who have MGUS or smoldering myeloma may be seeing their local oncologist who may not be up to date with all the new advances. So what piece of information would you give someone who's newly diagnosed with MGUS or smoldering myeloma?
So MGUS and smoldering are slightly different because the risk of progression for MGUS in general, if we put everyone together, is 1% per year, which is a very low risk. So we still observe them carefully. Hopefully we do the mutation status and genomic status to understand better, but we do not offer treatment yet, although we're thinking about, gentle things and things that, can we use aspirin or metformin to prevent further progression. So these are a class of agents that are very easy and simple. When we go to smoldering myeloma, and these are patients who have a little bit more disease, 10% in their bone marrow of plasma cells, the M spike is slightly higher, their light chains are higher, or they have bad cytogenetics, then we already know that the risk of progression is much higher, 10% per year. In fact, some of the patients have something called high-risk smoldering myeloma, which is 50% chance of progression over 2 years. That's a very high chance of developing myeloma within a very short period. These are the patients that we're telling them, come and consider clinical trial options, either with us or with other people. One of the trials that we just opened is something called elotuzumab plus lenalidomide. So this is a new antibody that has been tested in myeloma, and lenalidomide or Revlimid is a drug approved for myeloma. And that combination gives us 90% response rate in patients who already have myeloma or relapsed myeloma. So we're thinking probably that will give us even a higher chance of response when we use it in an earlier smoldering disease. And that's just one trial. There are multiple trials in multiple places to consider for smoldering disease. And I think the only way to know whether we can cure patients, whether we can achieve a deep response and prevent progression, is patients participating on some of those trials and seeing if they do really well, then everyone will suddenly change the way we think of treatment and start treating early, because it will make a huge difference in survival.
Well, basically, if you were doing MGUS or smoldering myeloma, you probably should go see a myeloma specialist to talk about some of the next steps, not just staying locally with your oncologist, just to get a better understanding of what's available to you.
Yes, I mean, even if you stay with your local oncologist, get in contact with one of us. And I'm happy to have email contacts. We're trying to make the website more informative for everyone so that people know and are informed. It's okay to see your local oncologist. In fact, we're trying to open some of those trials with the local oncologist because we know it's very hard for people to travel. But what's important is to be well informed and to know your own options and to know what are the limitations of just being in the local place versus going somewhere else.
Thank you so much.
Yes, thank you, Cindy. Pat, you online?
I'm here, Gary.
All right. Pat, your question.
Hi, doctor. If you remember, we met, I was at Crowd Care Foundation dinner with Gary sitting across the table. And
yes, of course, I do remember you very well.
I thought it was ironic because earlier in the day I had been with Gary and we attended the session that he referenced before, and he was quite taken with you. And if I didn't know his delightful wife and know that he was happily married, I'd say he had a thing for you. He just sat there mesmerized watching your presentation, and I was like, my eyes were glazing over, but he was just fascinated with what you had to say. And I have to tell our listeners, Gary, sometimes he overdoes these introductions a little bit, but Doctor, you are very, very bright, very impressive. I love your enthusiasm. It's inspiring.
Oh, thank you. I really appreciate this.
So if I could change gears just a little bit, this is out of left field because we've been talking about early diagnosis and treatment, but can you provide any insight into why a small percentage of myeloma patients end up with extramedullary, these outside the bone marrow tumors? I know some patients even get them early on, but a lot of late-stage patients develop them, and I hear from readers all the time asking, my doctor doesn't know what to do, because, of course, Revlimid and Velcade and a lot of the similar drugs are meant to attack things in the bone marrow, correct? Do you have any thoughts or insight into that?
Yeah, great question. So we call that extramedullary disease, and the question, and we're trying to study that both in the lab and in the clinic. So in the clinic, we have 2 papers that will come out very soon looking at our experience at Dana-Farber with patients who developed extramedullary disease. Were they treated with certain drugs or not? What were their presentation? What happened? How did we treat them? And so on. So that gives oncologists all over the world an option of what are the treatment options that we've used. Then we also looked in the lab, well, why would some cancer cells, the myeloma cells, that love to go to the bone marrow suddenly decide that they don't like the bone marrow that much anymore, and they now want to go to the skin or the liver or other places, which is that extramedullary disease. And there are 2 options for that. Either the cancer cells are so smart now that they develop new mutations, and that allows them not to stick anymore to the bone marrow, or it could be that the environment around them has changed enough and now they're starting to get out of the bone marrow. And we did some mouse modeling, and that paper is not out yet, but we've actually identified certain genes that will allow cancer cells to be able of going out of the bone marrow and sticking to other places. And hopefully, as we understand this better biologically, we can then develop drugs specifically for that. So there is a lot of work ongoing on this. You're right, we don't have good treatment options for extramedullary disease, but the hope is that as we understand it better, then we can target it better.
Sure. So if I'm a patient and I'm going through that right now, what do you do?
Yeah, multiple options. It depends on what they've received before, but usually we try to use combination of therapy, multiple drugs put together to really attack it better. We still
sure. Do you use cytotoxic
inhibitors.
Agents, maybe something that aren't they better? More general chemotherapy type drugs that aren't restricted to the bone marrow.
Not necessarily. We could use cytotoxic chemotherapy, like you said, but with a proteasome inhibitor or with also other agents. And when we put them together, can we kill enough of the cancer cells and prevent the progression? Having said that, I don't think we're doing a good job yet in developing treatments for extramedullary disease. Maybe the new antibodies that are coming out, the CD38 antibodies and other agents will be better in this, but we don't know yet.
Yeah, that makes a lot of sense. It's just the despair that you read in these people's emails, because their doctors basically throwing up their hands and saying, I don't know what to do, and the best I can tell them is head to a major, a place that treats and sees a lot of myeloma patients like Dana-Farber.
Yeah, absolutely. So these are cases, yes, absolutely. Go to a major center of myeloma. It doesn't have to be Dana-Farber alone. Any other center where they have a lot of options as well as new clinical trial options, because this is where we can hopefully have some of those new drugs that we're developing right now.
Wonderful. Thank you, Doctor.
Sure.
Gary, I'm set. Did we lose him? Matt, are you there?
I think
I'm here.
Next time.
Pat, I think you must have embarrassed Gary, so he had to get off the line or something.
He's explaining to Anita.
Yeah, you got him in trouble.
Yeah, Matt, why don't you
Yeah, thanks for your time, Doctor. I'm just trying to wrap my head around this concept of curing and preventable. So when you treat, or when you talk about treatment for patients with smoldering myeloma, is it treatment that is for a fixed period of time, or is it kind of like folks that have, partial response or complete response where they're still doing maintenance? Is smoldering the kind of thing where you'd be treating it indefinitely?
Great question. So when we were starting to design the clinical trials, we asked exactly this question. Well, if I start doing induction therapy that we do for myeloma followed by maintenance, then all we've done for the patient is just brought everything earlier, and is that really the best choice for the patients? And what we've designed our trials right now is that they are a fixed period of time, that we do maybe a little bit more intensive early on to really kill as many cancer cells as possible, followed by a little bit less, but we do not do maintenance forever. We're doing, in our trial right now, the treatment overall, including maintenance, is 2 years. And the reason for that is we said, let's achieve a good remission, follow it by some maintenance, and then stop. And hopefully, if you really stop and you've achieved a good remission, maybe that's where you can actually see the difference. If someone is cured, then hopefully the myeloma will never come back. If someone had a good remission for years and years, then at least you've prevented progression, and you can always come back later on if progression happens to consider treatment. But we do not want to keep patients on treatment continuously, at least at that stage.
Right, because it seems like for somebody that's not symptomatic, explaining to them that you're going to be on treatment for a while, I would imagine there's a challenge with that, I would think.
Correct.
Getting patients to be okay with that.
Exactly.
And
I'm
sorry, go ahead.
No, I was just going to say the other options we're trying to think of is something like vaccine therapy. So we do have a trial right now of only 3 months of Revlimid plus a vaccine, and trying to see with a vaccine can you make the immune system attack the myeloma cells much faster. So these are very short duration of treatment, but hopefully a big effect.
So the vaccine would be, the goal of the vaccine is to help the patient's immune system, as opposed to, we don't really know what causes myeloma, so you're not necessarily giving someone a vaccine to kill whatever brings about the myeloma, but you're just boosting the patient's immune system. Is that correct?
Correct. If the immune system can attack the cancer cells, that's all you need.
Okay. And in terms of causes and things, are you noticing that there's any changes in the demographics of new patients? Are they getting any younger? Are you seeing any changes over the last few years?
No, and I think Dr. Bob Kyle, who I trained with at Mayo Clinic, and I adore him. He's 80-something years old. He's the grandfather of myeloma. He's the one who described MGUS and smoldering, one of the best people you can think of in the world. And he had looked recently at whether the incidence of MGUS or smoldering has changed, or whether the incidence of myeloma has changed at all. And if I remember correctly, the publication showed no difference and no increase in the incidence of myeloma.
Mm-hmm. Okay, and do I have time for one more just quick question here? In terms of immune system and having a strong immune system, do you recommend that patients with MGUS or smoldering make changes to nutrition or to some of the things, lifestyle changes that might help boost their immune system?
Great question, and we don't know. So we don't know what goes wrong in our immune system to allow progression. We're still studying that in the lab. So we don't know what to tell patients to take or not to take. We're actually studying right now if obesity, or if we change the glucose level of patients insulin resistant. So if they have diabetes or if they're taking metformin, which is a diabetic drug that actually has been shown recently to have anti-cancer properties, can we prevent progression? And these are the things that we're trying to see if drugs as easy as metformin or as easy as aspirin can potentially change things. So these are the few things that we can say as potential changes early in MGUS, but I don't know the answer yet, and I would not recommend anything until we have proof of it or until we have a clinical trial to ask the question.